Welcome. In this lecture, we'll examine therapeutic hypothermia for neonatal hypoxic-ischemic encephalopathy, drawing on the 2026 American Academy of Pediatrics clinical report by Zanelli and colleagues. Hypothermia remains the only proven neuroprotective therapy for HIE, and over the next 40-some slides, we'll move from the underlying biology through the trial evidence, the eligibility criteria, the cooling protocol itself, the genuine areas of controversy, and finally, what it takes to run a cooling program well. This is pitched at the consultant and fellow level, so we'll assume the fundamentals and spend our time on interpretation, nuance, and the decisions you actually make at the bedside. I'm Dr. Adnan Hadid, and I'm glad you're here. Let's begin with what we want you to take away. Here are our 6 objectives. First, to ground ourselves in the pathophysiology of hypoxic-ischemic injury and why a narrow therapeutic window exists at all. Second, to appraise the randomized trial and meta-analytic evidence that made cooling standard of care. Third, to apply the biochemical and neurologic eligibility criteria, including the modified SARNAT examination. Fourth, to describe the standard protocol, its temperature target, duration, rewarming, and how cooling travels on transport. Fifth, to navigate the genuinely controversial areas, mild encephalopathy, late preterm infants, and initiation beyond 6 hours. And sixth, to outline neuromonitoring, neuroimaging, and the components every cooling program needs. Keep these in mind as we go. Each section of the talk maps directly onto one of them. Let's start with the foundations.
Section 1. Foundations. Before we talk about evidence or protocols, we need to be clear about the clinical problem, the mechanism of injury, and why timing dominates everything that follows. Why does HIE still command our attention in an era when cooling works? Because even with optimal therapy, somewhere between 29 and 40% of these infants still die or develop moderate to severe disability. That residual burden is exactly why the field keeps searching for adjuvant therapies. 2 numbers should anchor your thinking. A number needed to treat of just 6 to 7 to prevent 1 death or disability, and an established eligible population of infants born at 36 weeks and beyond. HIE is neonatal encephalopathy caused by perinatal asphyxia, and it's a common cause of encephalopathy. But remember, providing hypothermia does not by itself confirm a hypoxic-ischemic diagnosis. The consultant's task has shifted. It's no longer whether to cool, but how to cool the right infant quickly and well. That reframing carries us into the biology. The rationale for cooling lives in the time course of the injury. There's an initial insult, primary energy failure, when cellular ATP collapses and necrosis occurs at the core. But this is followed by a latent phase, a partial recovery of cerebral metabolism over roughly the first 6 hours. That interval is the therapeutic window. If we do nothing, secondary energy failure follows over hours to days. Delayed mitochondrial failure, excitotoxicity, and apoptosis. And that is the injury hypothermia is designed to blunt. The preclinical evidence is striking. In animal models, cooling the brain to about 32 to 34 degrees, started within 5.5 hours of the insult, improved both neuropathologic and functional outcomes. That single observation is the basis for the 6-hour clinical window we'll keep returning to. So the whole therapy is a race against the closing of that latent phase. Let's make the window concrete. We have roughly 6 hours from birth to initiate cooling, and benefit is greatest the earlier we start within the latent phase. Every hour of delay narrows the opportunity. Mechanistically, hypothermia slows cerebral metabolism, dampens the excitotoxic and apoptotic cascades, and attenuates that secondary energy failure. The practical target is to drop brain temperature by 2 to 3 degrees for a prolonged period, and the early safety studies showed that's both feasible and well tolerated, with minimal hemodynamic consequence. The goal throughout is neuronal rescue, converting potentially salvageable tissue into survival without major disability. The takeaway for your unit is simple but demanding. Cooling is time-critical neuroprotection. Recognition and initiation, or transfer, has to happen within hours of birth, not after a complete diagnostic workup. With the biology in hand, let's look at the evidence that proved it works.
Section 2. The Evidence Base.
6 landmark trials, 2 decades of meta-analysis, and the outcomes that moved cooling from experiment to standard of care. The story unfolds over about 15 years. Before 2005, animal models and small pilot safety studies established that cooling was feasible and safe. Then, between 2005 and 2011, 6 large randomized trials enrolled roughly 1,300 term and near-term infants. On the strength of those results, in 2010, ILCOR and the Neonatal Resuscitation Program declared cooling standard of care, and through the 2010s, it was implemented widely across high-income centers. Then, in 2017, the NICHD optimization trial showed something important. Outcomes had improved over time. The optimization cohort had markedly better results than the original 2005 study, mortality of 9% versus 24%, and death or disability of 29% versus 44%. Some of that reflects a milder case mix, but also faster initiation and better supportive care. Implementation itself matters. Let's look at those founding trials more closely. Here are the 6 trials side by side. CoolCap and the Chinese Selective Head Cooling Study used head cooling. NICHD, TOBY, Neo.Neuro Network, and ICE used whole body cooling. Individually, they ranged from about 129 to 325 infants, totaling around 1,300, roughly 900 whole body and just over 400 head cooled. Despite differences in selection and method, they shared a remarkably consistent protocol. Randomization within 6 hours of birth, a target of 33.5 to 34.5 degrees, 72 hours of cooling, and slow rewarming. Each was powered for the same composite: death or major neurodevelopmental disability at 18 to 24 months. 2 practical notes for today. Whole body and selective head cooling can be considered equivalent, but selective head devices are no longer available, and whole body cooling facilitates EEG monitoring. So in practice, whole body cooling is what you'll use. Now to what happens when you pool these trials. When you combine the pilot study and the 6 large trials, cooling reduces the composite of death or major disability by 24%, a relative risk of 0.76. Look at the forest plot. The benefit holds across severity, with a relative risk of 0.67 in moderate encephalopathy and 0.83 in severe. And crucially, neither confidence interval crosses 1, so both groups benefit. The larger Cochrane review, spanning 11 trials and over 1,500 infants from 35 weeks upward, confirmed the picture. About a 25% overall reduction, 32% in moderate and 18% in severe disease. This is about as robust as neonatal evidence gets. Multiple independent trials, consistent direction, and a coherent gradient by severity. Let's separate the 2 halves of that composite, starting with mortality. Mortality alone tells a compelling story. Compare the NICHD optimization cohort with the original trial. In-hospital mortality fell from 24% to 9%. Some of that is milder case mix and better care, but the direction is unmistakable. And the benefit is durable. At 6 to 7 years of age, cooling was associated with a relative risk of death of 0.66 and a relative risk of death or cerebral palsy of 0.71, both statistically significant. Now, be honest about the one caveat. The school-age composite of death or IQ below 70 narrowly missed significance, with a p-value of 0.06. But the mortality and death or CP benefits held, which supports the durability of the effect into childhood. So cooling doesn't merely delay death, it prevents it, and that protection persists. Next, the disability side of the ledger. What exactly do we mean by major disability? In these trials, it's a composite: cerebral palsy with a gross motor function level of 3 to 5, developmental delay, 2 or more standard deviations below the mean on Bailey or Griffiths, an IQ more than 2 standard deviations below the mean, or blindness or sensory neural deafness requiring amplification. Against that definition, cooling reduced disability by 32% in moderate and 18% in severe HIE, and 4 of the 6 original trials reached statistical significance, a robust pooled effect. One honest caveat, though: long-term data are limited. The trials were neither designed nor powered for childhood follow-up, and retention was difficult.
At 6 to 7 years, that death or IQ composite narrowly missed significance. So counsel families with confidence about infancy, but with appropriate humility about the longer horizon. Let's translate this benefit into a number clinicians intuitively grasp.
Number needed to treat is how I'd frame the benefit for a colleague or a family. For moderate encephalopathy, you need to cool 6 infants to prevent 1 death or major disability. For severe encephalopathy, the number is 7. Put that in context. These are extraordinary numbers for any neuroprotective intervention in medicine, let alone in the newborn. An NNT in the single digits means that on a busy service, cooling genuinely changes the trajectory of children you will personally care for. It's worth carrying these figures in your head because they reframe the urgency. Every eligible infant you cool promptly is a real, countable chance to prevent lifelong disability. But no therapy is free of harm, so let's be equally clear-eyed about safety. Reassuringly, adverse effects were infrequent at the standard target. The most common, sinus bradycardia and QT prolongation, are simply expected physiologic responses to cooling, not complications. Thrombocytopenia, with platelets below 150,000, was modestly increased in cooled infants on meta-analysis. Hypotension and persistent pulmonary hypertension were slightly more common, but did not reach statistical significance. And coagulopathy, sepsis, and pneumonia were no different from controls. Subcutaneous fat necrosis and skin changes were rare. 2 clinically useful points. Continuing cooling appears safe, even during ECMO, and trials of deeper, longer cooling, 32 degrees or 120 hours, were stopped early for increased mortality. And the single most important safety message is the inverse of cooling. Avoid hyperthermia. In TOBI and NICHD, about 30% of controls reached over 38 degrees, with a 3 to 4-fold increase in death or disability per degree. Now, who exactly should we be cooling? Section 3. Who should be cooled? This is where trial inclusion criteria become a reproducible, time-critical decision you can make at 3 in the morning. Eligibility rests on 3 pillars. First, gestation and age, born at 36 weeks 0 days or beyond, and within 6 hours of life. That's the established trial population. Second, evidence of a peripartum hypoxic-ischemic event, usually biochemical, though qualifying clinical criteria can substitute. Third, moderate to severe encephalopathy on neurologic examination, or clinical or electrographic seizures. Here's the point that trips people up. A confirmed sentinel event is not required to start cooling. Eligibility deliberately targets infants who show moderate to severe encephalopathy and who may have had an acute hypoxic-ischemic event. You treat first and confirm the cause later. Waiting for diagnostic certainty wastes the window. Let's take each pillar in turn, beginning with the biochemistry. The biochemical criteria have 2 tiers. The primary threshold is a cord or blood gas within 60 minutes of birth showing a pH at or below 7.00, or a base deficit of 16 or more. If a gas isn't available, or the pH is between 7.01 and 7.15, or the base deficit is 10 to 15.9, the NICHD trial allowed entry with 2 additional criteria: an acute perinatal event, plus either assisted ventilation continued for at least 10 minutes or an APGAR of 5 or less at 10 minutes. You'll see minor variation across protocols. The ICE trial, for instance, used a base deficit threshold of 12. The single most practical takeaway here: advocate at every delivery to draw cord gases on any depressed neonate. A missing gas is the most common avoidable barrier to timely eligibility. Now to the neurologic half of the assessment. This is Table 1. The encephalopathy grading that drives eligibility. 6 categories, each scored as moderate or severe. Level of consciousness, lethargy versus stupor or coma. Spontaneous activity, decreased versus absent. Posture, distal flexion versus decerebrate. Tone, hypotonia versus flaccid. Primitive reflexes, a weak or incomplete suck or moro versus an absent one. And the autonomic system, constricted pupils and periodic breathing in moderate disease versus dilated, non-reactive pupils, apnea, and a variable heart rate in severe. An infant is eligible when at least 3 of these 6 categories score moderate or severe. Commit this table to memory. It is the operational definition of moderate to severe HIE, and its structure underlies essentially every scoring system in use. Let's formalize that scoring.
The NICHD Modified SARNAT examination operationalizes those 6 categories into a simple rule. If 3 or more of the 6 assessments are moderate or severe, the infant is a candidate for cooling. It's the predominant tool in the United States. You should also know the wider family of scores. The numeric total SARNAT, which assigns 0 to 3 per item and predicts disability at 18 to 22 months, and the Thompson, Miller, and Sibin systems as graded alternatives. One important pitfall: maternal sedation, general anesthesia, or magnesium can cloud the examination. When the picture is muddy, use serial assessment starting at 1 hour of age and insist that the exam be performed only by examiners with validated competency. The exam is the linchpin of eligibility, so the quality of the examiner is not a detail. One more eligibility pathway deserves its own slide: seizures.
Seizures occupy a special place in eligibility. As many as half of infants with moderate to severe HIE will seize within the first 72 hours, and a large fraction of those events are electrographic only, with no outward clinical sign. Clinical or electrographic seizures function as an independent eligibility criterion in most of the trials. Because subclinical seizures are invisible at the bedside, EEG is essential, and the International League Against Epilepsy is explicit that a definitive neonatal seizure diagnosis requires an ictal EEG correlate. The consultants take: a seizing encephalopathic infant qualifies for cooling even when the other criteria are borderline, and that infant mandates continuous neuromonitoring from the very start. Let's assemble all of this into a single decision pathway.
Here's the whole decision in one flow. Step A is the infant 36 weeks or more, within 6 hours of age, with suspected HIE. Step B are the biochemical criteria met: pH at or below 7.00, base deficit 16 or more, or the secondary tier. Step C is their moderate to severe encephalopathy, 3 or more of 6, or seizures. If yes, you initiate therapeutic hypothermia. 2 practical notes alongside the algorithm. First, start passive cooling at delivery. Turn off the radiant warmer the moment you suspect HIE, before every criterion is confirmed. It buys precious time inside the window. And second, for borderline cases, document the eligibility discussion and consider transferring to a cooling center for further observation and monitoring. Algorithms are clean. Real referrals are messy. So let's talk about that.
Practical referral decision-making comes down to a few habits. If you suspect HIE, cool passively now. Turn off the warmer and don't wait for the complete workup. If you're at a center that doesn't cool, document eligibility carefully, especially the severity assessment in borderline cases, and call the cooling center early. And call them for borderline cases too, not only the clear-cut ones. That's exactly where shared decision-making helps. Why the urgency? Registry data show that about 1/3 of HIE infants don't reach a cooling center until after 6 hours, which is the very case for cooling on transport, our next topic. The overarching takeaway: whether or not your unit offers cooling, hyperthermia must always be avoided in any infant with possible HIE. With eligibility settled, let's turn to how cooling is actually delivered. Section 4. How cooling is performed. The protocol that 1,300 infants validated, the temperature, the duration, the rewarming, and how all of it travels on transport. Here's the whole protocol on one timeline. Induction happens within the first 6 hours. Start passively, then move to a servo-controlled device. Maintenance is 72 hours at 33.5 degrees, with continuous EEG and brain-focused intensive care running throughout. Then rewarming, slowly, at 0.5 degree per hour over roughly 6 to 9 hours. After rewarming, MRI before discharge. If you remember nothing else, remember the 5 numbers along the bottom. Initiate within 6 hours, target 33.5, maintain for 72 hours, rewarm at 0.5 degrees per hour, and image after rewarming. Everything else in this section is simply the evidence behind each of those numbers. Let's take them one at a time, starting with temperature.
The target is 33.5 degrees, sitting within the trial range of 33.5 to 34.5. And the key lesson here is that deeper is not better. A 4-arm trial tested 33.5 versus 32.0 degrees, each for 72 or 120 hours. And it was stopped early because the deeper and longer arms increased in-hospital mortality with no offsetting benefit. So the evidence converges firmly on 33.5. Resist any temptation, born of good intentions, to cool more aggressively in a sicker infant. The data say that does harm, not good. The companion question is how long. Let's look at duration.
72 hours is the answer, when cooling starts within 6 hours of birth. And just as with temperature, longer is not better. Extending cooling to 120 hours did not improve the primary outcome. It stayed around 32% across all arms. And it was associated with more in-hospital deaths.
Controversial areas.
The optimization trial therefore supports exactly the current
and
standard.
shared decision-making
72
matters
hours
most.
at
These are the questions you'll
33.5
actually
degrees
argue about
begun
on round.
inside the window.
Mild HIE is the
symmetry is
fastest
worth
growing
stating
gray zone.
plainly to trainees.
We know these
We don't
infants
go
aren't
colder,
risk-free.
and we don't go
About a
longer,
quarter of mild
because both were
HIE
tested,
managed with
and both
usual
caused
care
harm.
have abnormal outcomes
Once
at 2
the 72
years,
hours
and the
are
prime
complete,
cohort found
how we
meaningful
return
rates
to
of
normal
disability.
temperature matters
But that
too.
does not mean cooling helps them.
Rewarming is not
A
an
meta-analysis
afterthought.
of
It's part of the
117
therapy.
cooled versus
The rate
non-cooled
is half a
infants
degree
with
per
mild
hour,
HIE
a slow,
found essentially
controlled
identical
climb
adverse
from
outcome rates,
33.5 back to
19.6
normothermia
versus
over roughly 6 to 9
19.7%.
hours.
Benefit has simply
Avoid
never been
rapid
shown in a
rewarming.
trial.
An abrupt
Yet
temperature
practice
rise
has
may
crept
worsen
upward
injury.
dramatically. In
And
one
keep the
registry,
EEG
the
running.
proportion of mild
Seizures can
HIE
emerge
cooled
during
rose from
and after
46 to
rewarming,
79%
precisely
over
when
7
monitoring
years.
is sometimes
And
relaxed.
cooling carries real
Think
costs.
of rewarming as the
Mother-infant
final,
separation,
vulnerable
disrupted
phase
breastfeeding
of a
and bonding,
72-hour
transfer, and
rather
prolonged
than the
stay.
moment you stand
3
back.
randomized trials.
And many
Comet,
of these
Cool
infants,
Prime.
of course,
And
are cooled at one
gestational
hospital
age
and treated
defines
at
a
another.
clear gradient.
So let's address
At
transport.
36 weeks and above,
Many eligible
cooling is
infants
established
are born
and
where
recommended.
cooling isn't
Below
offered
35
and need
weeks,
transfer.
it is not recommended.
The workflow is
The narrow
straightforward.
band in between
Identify
35 weeks
HIE
0
at the
days to
referring
35 and
hospital.
6/7
Call the
is
cooling center
genuinely
to
uncertain.
confirm eligibility.
The dedicated late
Begin
preterm trial,
servo-controlled
enrolling
cooling in the
infants
field.
from 33
Monitor
to
rectal
35 and
temperature
6/7
and vital
weeks,
signs en route,
found no
and
benefit
continue
and signaled
seamlessly on
possible
arrival.
harm. A 74%
cooling
probability of
before and
increased death
during
or
transport?
disability, and
Because
an
about a third of
87%
HIE
probability of
infants
increased
don't
death.
reach a cooling
So for that
center until
35 to
after 6
35 and
hours.
6/7
Transport
span,
cooling
evidence
is how
is
you
limited.
close that gap
Decide
and
case
stay
by case,
inside the window.
discuss risks and benefits
There's no
frankly
large
with the family,
randomized trial
and
here,
document
but
clearly.
observational
Below
data support
35
transport
weeks,
cooling
the
if
answer is
strict
simply
protocols
no.
are followed.
The third co.
And the
What
crucial
about
safety
infants who
point,
present after the
without a
6-hour window?
servo-controlled device,
A Bayesian
you must
randomized
monitor
trial
rectal
studied
temperature and
initiation
vitals
between 6
closely
and
to
24
prevent
hours,
overcooling.
cooling for 96
That contrast,
hours. The
passive
result was a
versus servo,
76%
deserves a closer
probability
look.
of some reduction
Let's
in death
compare
or
the two
disability,
methods
with an
directly.
adjusted relative
Passive
risk of
cooling means
0.86,
turning off
but a
the
wide
radiant
credible
warmer
interval,
and letting temperature
and,
drift
importantly,
down.
a small
Its
effect.
virtue is
The consultant's
immediacy.
reading.
You can
The
start
benefit
at the
is
instant
small
you
and
suspect
uncertain.
HIE.
This absolutely
but it's a
does not
bridge,
change the
not a
priority of
destination.
early identification
Temperature
and
isn't
prompt
regulated,
cooling.
there's
But
a
for
real
an
risk
infant
of
who missed the
overcooling,
window,
and it
cooling
demands
between 6
close
and 24
rectal
hours
temperature
may be
and vital
considered,
sign monitoring.
after a frank discussion of modest
Servo-controlled
benefit
cooling,
and
by
real
contrast,
risk,
uses a
documented in the
device that
record.
continuously
Let's step back and
regulates to
organize all
target
these
through
controversies
feedback.
by
It
strength of
produces
evidence.
significantly
This
less
slide is worth
overcooling
pausing
and
on,
far better
because it's how
success
I'd want you
holding
to hold the
temperature and
whole
range,
field in your head.
which is why it's preferred
Established
whenever available,
with strong
including on
randomized
transport.
evidence. Cooling at
The practical synthesis
3.5
is
degrees
simple.
for 72
Start passive
hours within
immediately,
6 hours
then
for
convert to
36-week and
servo-controlled
older
as soon as you
infants
can.
with moderate to severe
That closes our
HIE,
protocol section.
emerging or
Now
uncertain,
to the harder
supported by
conversations,
limited or
where the evidence
observational
runs
data,
thin.
and